Lateral hip pain is a common orthopedic and sports injury that we'll encounter here at Rehab to perform. And typically when we're thinking of lateral hip pain, we're thinking of things such along the lines of trochanteric bursitis, gluteal tendinopathy, or maybe some sort of IT band syndrome. But typically with lateral hip pain, when we are ruling out any red flag concerns, it's going to come down to some sort of repetitive stress, overuse, or high volume or frequency activity that brought on this discomfort. So typically, you'll see this commonly in the running community. People who report pain with impact when they're running. When the foot hits the ground, they feel a sharp pain on the side of their hip. You may also encounter this, maybe not with the athletic community, but with your working population who is on their feet for a significant amount of time and being in a standing position, potentially in hard footwear, on hard ground, and having some excessive stress and strain on the lateral hip structures, and just some general fatigue and wear and tear on the muscles of the glutes and gluteal tendons. With lateral hip pain, I think we need to be mindful from an evaluation standpoint of how are we quantifying progress in regards to range of motion, strength, and overall pain profiles, and how are we communicating to our patient that everybody may present and progress a little bit differently. Some may see changes in pain rather quickly, whereas others may see changes in function rather quickly. With that, as people get better with pain, they can typically improve some of their functional performance metrics with regards to mobility and strength. For others, they may not experience that pain relief until they improve their mobility, strength, and overall endurance. So I like to paint that picture for patients and just give them a heads up that we're going to look at a variety of metrics. We're going to have kind of a nice balanced dashboard of things that we care about with regards to their progress, and we may not get everything changing and improving at the same time, but if we can identify that we are making progress in certain areas, we can help paint the picture for them that, hey, even if you're still having some of the discomfort, we're able to do far more things now than we were 2 weeks ago. Or, hey, even though we haven't made much change to your strength numbers or to your range of motion numbers, you're not having pain when you're getting out of the bed in the morning. It's not taking you 10 or 15 minutes to move around and get loosened up before you feel good. So make sure you set expectations early on what you think the lowest hanging fruit are, and what you think that biggest rate limiting factor is, that if you can address this one piece, the rest of the dominoes will fall into place for them. In the evaluation, I like to look at, first off, just sagittal plane competence. What's this individual's hip flexion and extension look like? And if they are lacking something in the sagittal plane, they may be compensating with excessive lateral deviation, notably in their weight-bearing activities. Very commonly seen with our athletic population when they start to make some compensations in the weight room with their different strength training and athletic movements there. You may also see it in your adult population just with how they perform daily activities and what their overall movement strategy looks like, just to do simple things such as walking, navigating stairs, or carrying about their general work activities. So make sure we're looking at things such as knee to chest, straight leg raise, prone knee bend, maybe even a Thomas test would be appropriate to look at hip extensibility there. From there, we can look at hip abduction and adduction. Do we have any gross discrepancies there? Or more importantly, how well do we tolerate that, both passively and actively? If we know that the lateral hip structures are going to be largely incorporated with abducting the hip, we want to see how they can tolerate that in a passive and an active environment. And that may clue us in more, is this more of a bursitis or is this more of a muscle or tendinopathy type issue there? And that can cater how we go about our plan of care and some of the interventions that we select. We also need to be aware of what does our rotational profile of the hip look like. Do we have good external rotation? Do we have adequate internal rotation? Are we somebody that may be more retroverted or anteverted by nature? And how is that going to influence their performance of some of the stretches or activities you want them to do in the future? And how should we temper expectations as to what our ceiling with some of those stretches may be as well? From a strength standpoint, I think it's very important to look at just isolated localized tissue tolerance and strength with abduction, extension, and flexion. And we can start to get a picture of, is this global irritation with all hip motions that's bringing on discomfort, or is it isolated to mostly either our frontal or our transverse plane tasks? With that, that can be something as simple as manual muscle testing. If we're looking at open chain, just manually resisted activities, you could also take them through different bridging and plank series. A side plank is a great way to look at not only lateral core, but lateral hip strength and endurance. And we could also look at something like a Copenhagen to see how the complementary adductors are functioning and if we have any areas for opportunity of improvement there. With bridging, we can look at them on just a traditional hook-lying bridge. We can put them in a feet elevated position if we want to exaggerate the amount of hip extension that they're going through and seeing what their competency and control looks like with that. And then obviously you can go into some single leg bridge progressions to see if we have either any limb symmetry, asymmetries that we need to clear up, or if there's a drastic change in their bilateral strength compared to their unilateral strength in general. Other things that we also might be interested in is what is the terminal task or activity that they're trying to return to, because this will also clue you into how in-depth you need to go into your evaluation from a testing standpoint. If they're trying to return to high-level, high-intensity, impact-related sports, it may be beneficial to do some sort of pogo testing or even potentially just some general observation of them going up and down the turf with different athletic movements. If there's somebody who may be more sedentary in nature or doesn't have large aspirations to get back into some of your higher intensity athletics, you may not need to go down that route. With regards to early interventions, I like to think that there's some things we can teach them from a self-care standpoint to desensitize that area, either with manual massage or teaching them some foam roller or self-MFR techniques. You can give them some targeted mobility for that area. I tend to have just general go-tos for this. Often they lack hip extension, and if they lack hip extension, I'm going to look at like a couch stretch or some sort of front foot elevated hip flexor stretch. A pigeon pose or any modification of a pigeon pose, either on the ground or elevated at a table, tends to target that area very well. And if they had any discrepancies with knee to chest or straight leg raise, you may want to look into some sort of hamstring mobility as well. From a strength standpoint, I like to start off with something local to that tissue, side plank, or maybe a long duration isometric for a side-lying leg raise or a clamshell if they had more rotational bias with their weakness or their intolerance. And then in a weight-bearing standpoint, I try to give them some sort of compound movement that is largely sagittal plane. Whether it's hinging or squatting, I'm not as concerned with, but I want to give them something sagittal plane. And if I want to give them a bias to get a little bit more of that lateral hip involved, but without stressing it too much, I'll put them into an asymmetrical stance with that. Progressions from there, with regards to your strength training, can be loading asymmetrically as well. So maybe we're taking something like a split squat and we're able to put the weight in the contralateral arm of the leg that is in front of them. So if the left leg's in front, the weight's in the right hand, that's going to give them some more frontal plane instability that they'll need to tease out and counteract with that lateral hip musculature. In addition to some Palloff press variations are great to do as well. As they demonstrate the ability to tolerate that, then I feel more comfortable getting into true frontal plane loading with something like a lateral box squat or getting into your rotational lunge matrix or any more of your multiplanar strength related tasks. As that gets tolerated better, I think just a general progression into lower level plyometrics such as pogos or some of your light hopping and bounding series, and then eventually we're working into our return to run programming. So there's a variety of ways that you can go after lateral hip pain, but hopefully this provides you with some general ideas as to how to approach the evaluation and some thoughts going through the rehab process.